Hi, everybody. I'm Mohamed Mohty from the Sorbonne University and Saint Antoine Hospital in Paris. And it is my great pleasure to welcome all of you to this IACH special web conference dedicated to the role of the microbiota and cancer. It's 6 p.m. in Paris, 5 p.m. in London, noon in New York. Wherever you are, welcome to this really exciting activity. And I don't need to spend a lot of time to convince you that the microbiota probably represents for the near future the new frontier in health and in medicine. Last week, probably you've seen the New England Journal of Medicine paper about FMT in Clostridium difficile infection. Just yesterday, we've seen a paper in Blood about the impact of the microbiota on immune recovery. And actually, you have papers now involving or highlighting the interactions of the microbiota with different diseases and different, I would say, treatment settings. So for the next few years, it looks like that in addition to conventional chemotherapy, in addition to antibodies, drug conjugate, bispecific antibodies, cellular therapies, and the broader immune therapies, modulation of the microbiota is really emerging as the next pillar. So with this spirit, actually, the scientific committee of the IACH designed this educational activity to tackle the most important and hottest topics in this field. So tonight it is my great pleasure and honor to have with us really top faculty who have made some significant contributions to this field. Dr. Laurence Zitvogel from the Institut Gustave Roussy in Paris in France, Dr. Jonathan Peled from the Memorial Sloan Kettering in New York, Dr. Florent Malard from the Sorbonne University in Paris in France, and last but not least, Dr. Joël Dore from the INRA in France. And as you have seen from the program, we try to divide this into some key issues. We'll have first the global picture about the interactions between microbiota and cancer. We'll move to the interactions of the microbiota in a more narrow topic, the hematological malignancies. This is the IACH, International Academy for Clinical Hematology, guys. Then we'll go to therapeutic applications with Dr. Malard, and then Dr. Dore will discuss actually the optimal products to be used for microbiota modulation. Of course, this is meant to be a highly interactive activity, so I would kindly ask you to send your questions, your comments, whether you like it or you don't like something, just throw it on the chat box or the Q&A box, and I will do my best to share it with the speakers, because after the talks, we will have some sufficient time for roundtable discussion. So without any further delay, I'd like to introduce Dr. Laurence Zitvogel, who is really a very famous immunologist who contributed a lot to the field of immune therapy. And in the last few years, she has dedicated her research effort to try to decipher the role of the microbiota in cancer with some very important and key findings. So Laurence, thank you for accepting our invitation, and the floor is yours.
Thank you, Dr. Mohty. Thank you, dear colleagues, for your attendance. So today I will try to highlight a few points underlying the relevance of the gut microbiota in cancer therapeutics, and specifically in immunotherapy. So I have a couple of disclosures. We were very proud that the Nature editorial board selected as a milestone number 13 the gut microbiota as one of the major breakthrough in 2020 for the field of oncogenesis. This is due to seminal contributions of incredible individuals that are all photographed here, namely Jen Vargo, Giorgio Trinchieri, Bertrand Ruti, and Tom Gajewski, without mentioning Lisa de Rosa in my group. So you know that immunotherapy has now become quite mainstream as a first line, but also second line across different malignancies. However, despite this FDA and EMA approval, only 30% of individuals of patients are actually benefiting from these therapies. And as you know, the immune system can be ignited according for their duration, the threshold and the magnitude can be modulated or governed by a variety of different factors. And I will not dwell on that, I have no time, but just suffice to say that the microbiota now is becoming recognized as one of the major internal parameters that will govern the tonus of the peripheral immune system. So back 10 years ago, Marie Vetizou in my lab was able to show that the anti-CTLA-4 antibody CTLA-4 antibody was actually more efficient in mice with an intact microbiota, while reduced in its activity in germ-free or in antibiotic-treated mice. And this was extended not only to CTLA-4 blockade, but also to other therapeutic modalities such as the cyclophosphamide, platinum salts, other immunotherapies, namely IL-10 blockade and PD-1 anti-PD-1 antibodies. And it was extended to a variety of different kinds of transplantable cancer models. Since then, 4 lines of evidences have been quite well documented. The negative impact of antibiotics on the clinical benefit to immunotherapy in cancer that I am going to detail below. Then the fact that the metagenomics-based fingerprints can serve as diagnosis tools for the diagnosis of prediction of resistance to immune checkpoint inhibition. Then the avatar mice that are humanized at the level of the gut that can be useful tools to predict the efficacy of different kinds of microbiota-based interventions. And finally, pilot studies aimed at transferring microbiota, so complex ecosystems from responders into non-responders. So I'm going to dwell upon these 4 points so that the audience have a broad view on where we are standing in this field. So quickly, back in the 2018, Ruti and colleagues reported that up to 30% of cancer patients are actually taking beta-lactams or fluoroquinolones, and that is necessary and sufficient to dampen the clinical benefit to anti-PD-1, anti-CTLA-4, anti-PD-L1, and that was obtained in non-small cell lung cancer, kidney, and bladder tumors at the second line of administration. The negative impact of antibiotics was not only shown in univariate, but also in multivariate analysis, and was overcoming that observed with steroids and proton pump inhibitors. Later on, 38 independent studies encompassing more than 11,000 patients were gathered in this meta-analysis, showing that the antibiotics are really deleterious when they are taken prior to immunotherapy or just right after the first administration, but we are not deleterious afterwards. And this was corroborated by other groups, showing that indeed the antibiotics were actually deleterious, mainly for immunotherapy and not for chemotherapeutic agents. So it took us 5 years to actually unveil the mechanism by which antibiotics are more immunosuppressive prior to immunotherapy than during immunotherapy. And this is a graphical abstract of the data that I'm going to present quickly. So we showed that after antibiotic stops, there is a recurrence of enteroclusters, mainly Clostridium clostridioforme, Clostridium boltae, and immunosuppressive Clostridium that have been renamed enteroclusters. And this bacteria can dampen or downregulate the expression of MAdCAM, so the mucosal addressine that is normally expressed on high endothelial venules. And by doing so, the alpha-4 beta-7 positive regulatory T cells that normally bind to MAdCAM leave the gut. So these enterotropic suppressor cells leave the gut and end up accumulating in tumor beds, promoting the flare-up of the cancer. And so we showed, for instance, in a tumor-bearing mice, that anti-PD-1 antibodies will not work when the alpha-4 beta-7 MAdCAM axis is disrupted. For instance, in animals that are bearing genetic deficiency for beta-7 integrins or MAdCAM adenosine, or in animals treated with neutralizing antibodies anti-MAdCAM or anti-alpha-4 beta-7 heterodimeric molecules. And so this is interesting to see that, for instance, the ileal MAdCAM levels are really downregulated after antibiotics uptake. This is not seen in the colon. It's only a feature of the ileum. And we can document this downregulation not only at the mRNA level, but also at the protein level, using either immunohistochemistry or stainings, or using FACS analysis or ELISA of the whole mucosa. Importantly, broad-spectrum antibiotics, but also ampicillins and also streptomycin can do so. However, vancomycin is not doing it, because vancomycin is killing the enteroclusters, and these enterocluster species are really sensitive because they are gram-positive bacteria. So there are lots of implementation of this work. So for instance, if you transfer fecal microbial materials into mice from a non-responder person, you will downregulate ileal MAdCAM. In contrast, by co-transferring good bacteria that have a beneficial immunologic property, such as the Akkermansia mucinifila or Enterococcus cereus, you can upregulate the MAdCAM levels. You can restore the MAdCAM levels. So Akkermansia, by restoring MAdCAM levels, will prevent the recirculation of alpha-4 beta-7 T cells, namely most of them being TR17 regulatory cells. And so you see that, for instance, if you take 6 fecal microbial transplantation into mice, you see that 3 of them are coming from donors that actually do not modulate MAdCAM, ileal MAdCAM. In striking differences, you see that 3 other donors transfer a microbiota that will downregulate ileal MAdCAM. And when we do this clustering of the taxonomic composition, we can segregate the green feces from the red feces, if I can say so. So the good one from the bad one, the one that downregulates MAdCAM, just by the composition. And you see that the enteroclusters, the enterocluster boltae, Symposium, and Clostridioforme, for instance, are dominating those that downregulate MAdCAM and will allow the translocation or the emigration of the enterotropic Treg cells from the gut to the tumor. So, in other words, this first part is showing that antibiotics, when stopped, will allow the recurrence of certain types of gram-positive bacteria that downregulate MAdCAM, and by doing so, they promote the elimination from the gut of the regulatory T cells, thereby accelerating tumor progression. The second line of evidence is the composition of the gut microbiota using the shotgun metagenomics analysis. And I have to thank INRAE and in particular Joël Dore and Dushko-Erlich for their capacity to help us to delineate the beneficial bacteria from the harmful bacteria. In this issue of cancer discovery, we align on the left side the good bacteria that promote or that dictate or govern the chances that the PD-1 blockade will be accompanied of a clinical benefit, so namely the Lactobacillus as well as the Verrucomicrobiaceae, Ruminococcaceae, and Faecalibacterium prausnitzii, all are on the good side. The other harmful bacteria are namely those that dampen the efficacy of immunotherapy, and they are belonging to the proteobacteria, the enteroclusters that I was alluding at, as well as Egertella lanta, Actinomyces, and Atopobium parvulum that are reproducibly associated with failure to immunotherapy. So one of the reasons why cancer patients are showing up with gut dysbiosis is explained on this slide very quickly. We just published that a month ago, so it's fresh new data. And we were able to show that when we inoculate a cancer and the cancer progresses in a host, this creates a stress ileopathy that is histopathologically defined by apoptosis of the crypt and a crypt-villus ratio, which is completely abnormal. And this creates a dysbiosis that is dominated by these enteroclusters species, not only in in mice, but also in humans. So the right-hand side is showing an alignment of the species that are dominating in 1,500 cancer patients across 8 different tumor types. And you see that cancer patients have a dominance of enteroclusters and a dominance of certain proteobacteria and so on at the expense of underrepresentation of Lactobacillus, so meaning that the balance between the harmful and the beneficial bacteria are in the wrong side. And so not all cancers do that, just in 50% cases, we observe these abnormalities, and this can be abrogated by vancomycin, which kills the gram-positive bacteria, namely the enteroclusters. Interestingly, this ileopathy and this dysbiosis results from an ectopic proliferation of neuroendocrine cells, so the cells from the ileum, and they overexpress tyrosine hydroxylase at the expense of cholinergic signals. And so we can prevent this cancer-induced stress ileopathy using beta blockers or beta-2 blockers or vancomycin. The fourth line of evidence is, the third line of evidence is the avatar mice. We could show that when we transfer the fecal material from patient into antibiotics or germ-free treated animals, we could somehow predict or anticipate the capacity of this patient to respond to PD-1 blockade, as we reported back 5 years ago, meaning that the fecal material from non-responders is going to transfer the phenotype to the mice. Conversely, when we perform the oral gavage using responder feces, we convey this favorable phenotype to the recipient. Finally, and this will be the end of this talk, I am going to show you 2 important trials, one from the Sheba Institute, using the fecal microbial transplantation in cured melanoma patient, transferred into primary resistance melanoma to PD-1 blockade. They used 2 different donors. One was conferring the reintroduction, was conferring a response to the reintroduction of anti-PD-1 antibodies, while the other donor couldn't do so. And this was reproduced in the second trial from the University of Pittsburgh, where here there were 15 individuals completely resistant as primary or secondary resistant to PD-1 blockade. In 1/3 cases, the mere transfer of fecal material from responders to them could reverse this resistance. And this was associated with a shift in the taxonomic composition of the microbiota, meaning the recipient of the fecal material resembled the donor composition, meaning that the Lactospiraceae and the Ruminococcaceae take the stage at the expense of Tannerellacea and Suterellacea. Importantly for us, not only the composition of the microbiome changed, but also the inflammatory tone was dampened, namely the IL-8 was downregulated, and we could see the emergence of flat-free ligand as well as CXCL13, which is a surrogate marker for an activation of follicular T helper cells in the blood of these patients. In addition, we could see an increased activation of CD8 effectors, mates, which is a subset of natural killer cells. And we also observed a modulation of the biliary salts, which are very important because they react to the composition of the microbiota. To finish, I would like to say that soluble MAdCAM is a surrogate marker of dysbiosis in patients. I was telling to you that antibiotics can dampen MAdCAM, and when you dampen ileal MAdCAM expression, you can also see a down regulation of the soluble MAdCAM in the serum of patients, so it's very practical. And we could show that patients bearing cancer presenting with very low levels of soluble MAdCAM have a very poor outcome following PD-1 blockade in 2 independent cohorts of more than 200 patients. And this soluble MAdCAM is associated with, so when soluble MAdCAM is low, alpha diversity is low, beta diversity is different from the subset of patients that present high serum soluble MAdCAM. And you see that in the hierarchical clustering of the taxonomic composition of the gut, the low serum MAdCAM is associated with the emergence of enterocluster boltae, enterocluster clostridioformis, and Velonella parvula, which are the bacteria associated with a harmful effect on the immune system. So I finish with this concluding slide before I acknowledge my people, that Gustave Roussy is now embarked into the clinical biome. So it's a deep cohort for any patient amenable to immune checkpoint inhibition at the first place. And we're going to propose 3 different clinical trials, one based on a nutritional intervention, free deoxybutyrate versus ketogenic diet, another one aimed at compensating Akkermansia negative patient into Akkermansia positive patient, and the third one that we are going to do with Joël Dore and the MAD Pharma biotech company, where we will treat antibiotic taken patients, so antibiotic-related resistance to immunotherapy will be treated with the reintroduction of cemiplimab together with a complex ecosystem from MAD Pharma. So I would like to thank all the contributors and the COVID team that killed 2 birds with 1 stone during this health crisis, and the network of key opinion leaders in France that helped me for all these conclusions. Thank you.
Thank you very much, Laurence, really, for a very, very beautiful and comprehensive talk. We can sense lots of passion, and we're very grateful for including actually unpublished data, which are really, really very exciting, especially this MAdCAM soluble story. So we'll discuss all this. We have already plenty of questions, so please stay tuned. if you have just joined, welcome to this special web conference by the IACH dedicated to the microbiota in cancer. And now it is my pleasure to welcome Dr. Jonathan Peled from the Memorial Sloan Kettering Cancer Center in New York in the US. And Jonathan has done some amazing work on the role of the microbiota in allogenic stem cell transplantation and hematology in general. And actually, we owe a lot to this group in New York, the lab of Dr. Vandenbrink, who have contributed. They have contributed a lot. So Jonathan will focus on allo and hematologic malignancies. So the floor is yours, and thank you, Jonathan, for joining.
Thank you very much, Mohammed. It's my pleasure to talk about the microbiome and not just Allo-HCT outcomes, but also a few other areas. These are my disclosures. So when patients undergo allogeneic bone marrow transplantation, there's a very profound dysbiosis or microbial injury that's induced. So a normal diverse microbiome might look like this, where the height of the bar is the full composition of the gut microbiome, and the relative abundance of each taxon is represented by the height of the bar. And as Dr. Zitvogel pointed out, there are organisms that are normal in the gut and ones that might be deleterious. These various shades of pink represent different lacnospiraceae. These shades of teal represent Bacteroidetes, which are all parts of a normal healthy microbiomes. And this patient received an allotransplant. Their white count went down to 0 and then later recovered. And during this time period, the patient received several different antibiotics. And shortly after starting piperacillin tazobactam, there was an expansion of Enterococcus faecium here in green that then took over to take up the entire content of the fecal samples with only one organism. This is a very unusual configuration of a gut microbiome sample that probably no one on this webinar has at the moment, unless someone's going through a bone marrow transplant at the moment. And this phenotype has been associated by my colleague Ying Tower with a 5 to 10-fold, in fact, perhaps in some cases much higher than that, risk for a bloodstream infection with a corresponding organism. So that's by way of why this might be relevant for infections, but it turns out that it's relevant for various other clinical outcomes as well. But before we get into that, let me show you a little bit about the patterns of microbiome damage that we see, besides just individual expansions. Here is a summary graphically of a multi-center analysis that we did of 8,600 samples from 1,300 patients, and the patients came from Regensburg in Germany, Duke and New York in the United States, and Hokkaido University in Japan. Each point is a stool sample, and they're arranged here on a t-SNE plot in the same way that a RNA-seq or a flow cytometry experiment might put each dot as a cell. Here, each dot is a stool sample, and the samples that are similar to one another in composition are close together, and the dissimilar samples are far apart. And you can see that there are clusters. For example, there's a cluster that's relatively early in time and various clusters that appear more at later time points relative to transplant. And these early clusters tend to be highly diverse, here with diversity measures that are in this orange and yellow range, whereas these later time points are various low diversity states, as indicated by the blue. And if we color code by the most abundant organism or the most abundant taxonomic group in each of these samples, we can see that these early samples, these diverse ones, are indeed enriched for things like lacnospiraceae in pink, and these injured states are enriched for organisms such as Enterococcus or Klebsiella or E. coli. And by the way, despite all the ethnic and exposure differences across these 4 centers and the variance in the way antibiotics are used and the way transplant is conducted at all these different centers around the world, the samples from all 4 centers explored all these compositions comparably. It's not as if the German samples were in one corner and the Japanese in another. So these patterns of microbiome injury are very consistent across transplant centers. And the patients who incur this microbiome damage have a higher rate of mortality. This was first observed by my colleague Ying Tower in a cohort of 80 patients. And here we see it at our institution in New York in a very large cohort, and also in the multi-center international validation set. And this relationship holds up to multivariate adjustment for various transplant and patient characteristics. So why do people die after a bone marrow transplant? The most common cause is relapse, and the balance of deaths are attributable to graft versus host disease, infections, and organ toxicities. And each of these outcomes have been associated with various microbiome compositions. So here is a phylogenetic tree of all the organisms that we've detected in patient stool samples, and the tree is circularized, and each tip is a different organism. And I've color-coded the clades that are associated with good clinical outcomes in blue, and the clades associated with bad clinical outcomes in red. I'll just point out, and by way of orientation, there's this large group of Clostridia, which are mostly salutary, homeostatic, helpful organisms, although there are counterexamples. For example, here in red is Clostridium difficile, familiar to all of us. So the group I'm privileged to work with has, for over 10 years, published many association studies linking each of these clinical outcomes with various organisms. Now, what about relapse specifically? So I asked a few years ago, are there associations between the enteric flora and relapse after allotransplant? Or phrased another way, can microbial biomarkers predictive of relapse be identified? And so first, we looked at diversity. And unlike overall survival, which is largely driven by transplant-related mortality with respect to diversity, there really was no relationship between the overall diversity of the gut microbiome fecal samples and the incidence of relapse. So I decided, after seeing this negative result, to look for individual organisms or groups of organisms that might associate with relapse instead. And I split up the patients that I had available, which was about 540 patients, into a discovery set and a validation set. And I systematically checked for the association of every taxonomic cluster that I could identify in the discovery set, and identified one named 1614 arbitrarily, which when present was associated with a much lower risk of relapse than when it was absent. And this was also true not just in a presence-absence format, but also when when this group of organisms with this number was measured as a continuous variable. And this was the top hit in the discovery set, and it turned out that it was also reproducibly observed in the other half of the patients that we had set aside as the validation set. Not only that, but this the abundance of this organism, or the presence of it, allowed us to further stratify relapse risk beyond the clinical variables that we already know about. So, for example, the disease risk index takes into account what type of histology the malignancy is and what stage of disease the patient has coming into transplant. And it, on its own, the DRI can stratify relapse incidence rather well in this cohort. But within the DRI high and within the DRI intermediate groups, this fecal feature could further stratify it. And this, we also showed this with a cause-specific C index, that it pushed the area under the curve even further. Although admittedly not great. We're not talking about AUCs of 80 here like a PSA test, but for allotransplant outcomes, 0.65 is an improvement over what clinical features afford. I'll skip this in the interest of time, and I'll show here this. We did a forest plot of all the various clinical features, and one feature that was interesting is that the signal was largely driven by patients who received T-replete grafts at our center, and was not seen significantly in patients who received T-depleted grafts. And this difference allows us to hypothesize that this group of organisms might be modulating T-cell alloreactivity and graft versus tumor effects. And interestingly, the two diseases that drove most of the signal were AML here and multiple myeloma. whereas the other histologies seem to not, on their own in subset analysis, have a statistically significant driving feature. So the most abundant organism in this cluster 1614 is something called Eubacterium limosum, which is a commensal microbe that is an anaerobic, non-spore forming gram-positive rod. And it has been used by prior researchers to ameliorate experimental colitis and also induce production of interferon gamma by peripheral blood cells. This should be PBMCs, not PBSCs. And our preliminary data suggests that it activates certain human toll-like receptors. So work is ongoing to try to understand if this is causative or just correlation. Let me also tell you briefly that we've seen some of the very same patterns of gut microbiome injury in recipients of Auto-HCT. And this is work that's done by my colleague Nilofer Khan, who's a member of our lymphoma service. So we collaborated again with Duke and assembled a cohort of auto recipients. And we saw that, I'll skip this in the interest of time, but we saw that just like in the allotransplant setting, there was an association between high diversity and longer overall survival, and specifically for progression-free survival, because there's not much transplant-related mortality, fortunately, in the auto population. And we saw some of the very same types of injury patterns in the auto patients as we do in the allo patients. For example, these dominations with Enterococcus and Streptococcus and Klebsiella. Let me skip in the interest of time. Oh no, I can tell you momentarily about immunoconstitution. Now, if we think that the main way that allotransplant helps deal with preventing relapse, besides the intensity of the conditioning itself, is by conferring a graft versus tumor effect. And there's also some mouse data that suggests that in auto transplant, there is also a graft versus myeloma effect, at least in the setting of myeloma autos. And so understanding ways to augment immunoconstitution, or ways that the microbiome might be modulating immunoconstitution after bone marrow transplant, could potentially have an impact not only on reducing the infectious toxicities of the treatment, but perhaps also reducing the underlying relapse rate. In a mouse model of syngeneic transplantation, my lab mate, she was in the lab now she's moved on back to her native Sweden, Anna Staffas, treated mice with antibiotics to reduce the burden of bacteria from control conditions to either one of these two antibiotic regimens, and achieved a 4-log reduction in gut bacteria, and then gave the mice syngeneic transplants and monitored immune recovery. In gray are the normal ranges for mouse white blood cells and white mouse lymphocytes, and the control animals by day 14 or day 21 recovered their normal counts. However, the antibiotic treated animals had sustained impairment of their count recovery. By the way, she also saw this in allo-transplanted mice. And this work is published, so I won't belabor the details, but one of the mechanisms by which this works, we think, is that the gut microbiome are helping these mice harvest needed energy from the diet to supply the incredible demands that a completely reconstituting hematopoietic system needs in the days after a transplant. And one of the lines of evidence for this is that this impairment, this antibiotic-induced impairment, could be fully rescued by administering sugar to the mice. Finally, I'll tell you about a fecal microbiome transplant trial that was run at our center. So these are patients who underwent an allo transplant, but received an autologous fecal microbiome transplant around the time of their BMT. So they banked their stool before their allogeneic bone marrow transplant, and then if they incurred a microbiome damage, as assessed by a PCR test of their poop after neutrophil engraftment, they were then randomized to either receive or not their own stool back via enema. And we noted that the patients who were randomized to their FMT had a more robust recovery in the first 10 weeks of their neutrophil, lymphocyte, and monocyte lineages. So all these lines of evidence suggest that if we can find ways to optimize the gut microbiome, perhaps we can improve clinical outcomes after bone marrow transplant ranging perhaps starting with immune reconstitution and infection prevention, but perhaps getting as well to graft versus host disease and relapse prevention. I'll point out that this might be important not only for allo and auto transplant, but also for CAR-T cells. So in collaboration with Melody Smith, who used to be my lab mate and now has her own lab in Stanford, we've observed that the fecal diversity drops around the time of CAR-T cell infusion in recipients of various types of CAR-T cells. And in work that was inspired by the antibiotic exposure observational analysis that Dr. Zitvogel just described, patients who are exposed to one of these 3 antibiotics in the month before their CAR-T treatment go on to have a worse overall survival in the 2 years following their CAR-T exposure. So we're actively trying to extend some of this work to the CAR-T cell setting. I'll be very happy to talk about various approaches to modulating the gut microbiome in the context of cancer treatment in the Q&A session after this. Thank you very much.
Thank you very much, Jonathan, for another beautiful talk, and congratulations for all the work you've done so far. But definitely, you have convinced us that time has come to modulate the microbiota, and it is feasible. We have the proof of concept. So at this stage of the web conference, again, welcome to this special web conference dedicated to the microbiota in cancer. Please do not hesitate to send your questions and comments. So I'm collecting all of them, don't worry. They will be discussed with the faculty after the talks during the roundtable discussion. So now it is my pleasure to introduce Dr. Florent Malard, who will discuss the modulation of the microbiota in clinical practice, almost in routine clinical practice. So Florent, the floor is yours.
So, thank you, Mohamed, for these introductions. So just, I will not go through the details of this slide because Professor Peled just gave us a very comprehensive talk that highlights the association between gut bacteria dysbiosis and allogenic stem cell transplantation outcomes. This slide is a perfect transition because it was the last slide of Jonathan, and I'm going now to discuss the strategy we can use to address, to prevent, or to treat microbiota injury in the setting of allogenic stem cell transplantation. So there is different aspects. We can work on the antibiotics, we can work on the prebiotics. The probiotics, it will be the main focus of my talk because this is regarding probiotics and in particular fecal microbiota transplantation where we have the more data available. And regarding postbiotics, so far we don't have data. It's not feasible because if you want to give some short-chain fatty acids such as butyrate to the patient, it is not feasible because they are not well tolerated. So it's just here on the slide to see that, yes, maybe it could be useful to give them, and in fact, there is some work on it, but I don't have any data so far to show you. So what we can do regarding antibiotics. So in this study performed by the Regensburg groups, they evaluate the impact of the antibiotics on patients' outcome according to the time we start the antibiotics. And as you can see here, in patients that receive antibiotics early before the day 0 of the transplant, the transplant-related mortality was higher, over 40%, and it was significantly higher compared to patients that received delayed antibiotics starting on the day 0 or after the transplant, or patients that did not receive antibiotics. So it includes an important number of patients, both from Regensburg and from the memorials, Sloan Kettering. So this is some kind of robust data. So it's already suggests that maybe when this is feasible, we should delay the antibiotics initiations beyond the day 0. Another study from the memorial look more closely to the impact of the kind of antibiotics we use. And they evaluate the antibiotics according to the impact of the on the anaerobic bacteria. There is antibiotics with an important impact of on anaerobic bacteria. This is imipenem or piperacillin tazobactam. Antibiotics with less anti-anaerobic effect, astronam or cefepime, for patients that did not receive antibiotics. And as you can see here, patients that receive these antibiotics with an important anti-anaerobic effect have a significantly higher GVHD-related mortality compared to patients that did not receive antibiotic or that receive astronam or cefepime as first-line treatment. So this suggests that maybe when this is feasible, we should use more this antibiotics with less anaerobic coverage, in particular cefepime, and avoid first-line treatment with piptazo or imipenem or meropenem. It is not always feasible, but when this is feasible, this is something we should definitely do to decrease the impact on the gut microbiota dysbiosis and improve patients' outcomes. Regarding prebiotics, there is also few data available. It was this first study that was presented 2 years ago at the ASH meeting when they used a resistant potato starch. So this is an indigestible carbohydrate that is metabolized by the intestinal anaerobic bacteria to produce butyrate. So butyrate have some immunoregulatory effects. So they give these treatments orally for day -7. So it started with the conditioning regimens up to day 100 after transplant, and they treated 10 patients. This is some very preliminary data. We don't have any result on the impact on patients' outcome, but it was feasible. The patients were able to take the treatments, and it was associated in red. This is the patients that take the red RPS with an increase into the butyrate producers within the gut bacteria and an increased level of butyrate within the stools. Another study that was published 2 years ago now with Blood Advances. It was a prospective study with 49 patients that were compared to an historical control groups with 142 patients. They received some prebiotics from start of the conditioning regimens until day 28, and they used the same resistance potato starch that will increase the butyrate producing bacteria and the GFO that associate glutamine, fiber, and oligosaccharide that was commercially available. As you can see here, the use of this was associated with the decreased incidence of grade 2 to 4 acute graft-versus-host disease. It was also decreased, but not statistically significant incidence of grade 3 to 4 acute graft-versus-host disease. And when we look more in details into the organ involved by the acute graft-versus-host disease, we see a decrease in skin all-stage acute graft-versus-host disease that was statistically significant. There was also an effect on the GI acute graft-versus-host disease, but it was not statistically significant. So we still need to confirm this study. It was not a randomized study. It was compared to an historical control, but this suggests that some gut microbiota modulations with these probiotics was associated with an effect not only on the GI acute graft-versus-host disease, but also some off-target effect on the skin acute graft-versus-host disease, which clearly highlight that gut microbiota has some effect on the immune systems and is a promising treatment also not only for GI acute graft-versus-host disease, but also for other organs. I will finish with the probiotics and mainly with fecal microbiota transplantations. It was some study from the Memorial where they performed some autologous FMT after allogenic stem cell transplantations to accelerate microbiota diversity. So this is an example of one patient. So this is a patient at baseline. To be included in the study, patients must have a good microbiota diversity at baseline because, of course, some of the patients already receive antibiotics or chemo for the treatment of leukemia, lymphoma, or other underlying disease. So the patient that already has some dysbiosis were excluded. If there is some healthy microbiota, it was frozen. He received the transplantations with the conditioning regimens, the antibiotics. It was the neutropenic phase. And as you can see, during the neutropenic, there is an important dysbiosis with the domination with enterococcus that is very orphan. or very frequent. And after engraftment, hematopoietic recovery, they performed the autologous FMT around day 49. And as you can see here, there was a restoration comparable to baselines of the gut microbiota diversity in those patients. So it was a randomized study with a few number of patients that were included that showed that it was feasible. The aim point of the clinical trial was to evaluate the impact on Clostridioides difficile infections, but there was not enough events and they were not able to see an effect on these endpoints. We performed a similar study, but not in the setting of allogenic stem cell transplantation, but of acute myeloid leukemia. It was some patients with newly diagnosed acute myeloid leukemia. And before they received any treatment, any chemo, any antibiotics, we collect some feces that were frozen. Also, it was a healthy microbiota. They received the induction chemotherapy, antibiotics, and after neutrophil recovery, we stopped the antibiotics and we performed the autologous FMT around day 29, and we assessed the gut microbiota diversity again 10 days later before we start the consolidation chemotherapy. 25 patients were treated. When we look at the alpha diversity with the Simpson index, we show that autologous FMT restores up to 90% of baseline diversity. When we look at the gut microbiota compositions with the Bray-Curtis index, which, as you can see here, this is in red, this is after induction chemotherapy. There is some important dysbiosis, and it's go back to baseline after autologous FMT. And very interestingly, when we look at the antibiotic resistant cyclopicot genes, we see that auto-FMT reduces the number of antibiotic resistant gene by 43%. Here, this is another representation. Here you can see that this is the Bray-Curtis index that shows the composition. The Simpson, this is the alpha diversity. It decreases after chemotherapy. We have an increase into the Enterococcus, the bad bacteria, and it's go back to baseline after FMT. Several studies have been performed. There is to evaluate autologous FMT in the setting of allogenic stem cell transplantations. It was a study by Dore et al. I showed you earlier. There was another study by De Phillips when they don't use enema but oral capsule with certain patients, and it was positive results. It increased the gut microbiota diversity. There is also some studies that were performed to evaluate the effectiveness of FMT for multi-drug resistance bacterial decolonizations. In the first study, 20 patients were treated, 8 of them after allogenic stem cell transplantations, and it was effective in 15 out of 12 patients. We performed a similar study in 10 patients, 4 before transplant, 6 after transplant, and we had a persistent decolonizations in 6 out of 10 patients. It was very successful. This is an example of one patient. As you can see here, this is the day 0 of the transplant, and these patients remain in the hospital more than 10 months after the transplantations because she was always presenting some Pseudomonas aeruginosa sepsis every 2 months. And it was impossible to discharge the patients, and we finally performed an FMT with the third-party donors, and within 2 weeks, the patient totally recovered. We don't see anymore the Pseudomonas aeruginosa infections, and she was discharged, and now she's cured at home for several years. Can we modulate the microbiota also to treat acute graft-versus-host disease? It was the first case report published now 6 years ago in Blood. When we focus, for example, in these patients, you have a very severe acute graft-versus-host disease with diarrhea, with abdominal pains, with blood in the stools. You are receiving steroids. They perform 2 FMT 2 weeks apart. And as you can see here, there was a decrease in dispersions of the symptoms, and at the same time, the gut microbiota that were dysbiotics recover to an healthy microbiota. In this study, 4 patients were treated and we achieved 3 complete response and 1 partial response. Overall case reports on small series were performed that also reported the very impressive complete response rates. This study that was the last published with the highest number of patients, 15 patients treated, 6 patients with steroid resistance and 9 with steroid-dependent acute graft-versus-host disease. At day 28, 10 patients were in complete response, and with a longer follow-up of 6 months, 6 patients remain in response, and it was associated with a high overall survival. We performed a similar study in Europe, evaluating allogeneic FMT for the treatment of steroid-resistant acute graft-versus-host disease with 24 patients treated. In this study, we don't use regular third-party donors. We use Malard that was a pool of several donors on this product. The use of pooling of donors will be developed in the next presentations by Professor Joël Dore. So we use this pool of donors and we perform 3 FMT 1 week apart, and we evaluate the response on acute graft-versus-host disease at day 28. I must highlight that we include very high-risk patients because it was only patients with GI involvement with early steroid resistance. So in these 24 treated patients, we reported an overall response rate of 38%, including 21% of complete response. And when we focus on the best response, it was 54%, and it translates into her 44% overall survival at 1 year in responding patients. In addition, we were able to treat also 52 patients with GI acute graft-versus-host disease that were not eligible to be included in the clinical trials and that were highly pretreated because they received a median of 3 lines of treatment, including 77% of patients that received ruxolitinib. And in those patients, the overall response rate at day 28 was 58%, including 33% of complete response, and it reached 67%. It will focus on the best response before day 28, and it was associated with a very high overall survival of 59% in the responding patients at 1 year. So now we are going to, as you know, ruxolitinib is becoming a standard second-line treatment for acute graft-versus-host disease. So now we are going to evaluate so this product, this FMT products MAT13 from a pool of donors as a third-line treatment in patients that resistant to steroid and ruxolitinib. So this clinical trial just opened in France and is going to open also in another country in Europe, and there is an expansion to the US side that is expected in 2022. It will be the same design with 1 FMT 5 days apart on the evaluations of the overall survival of the response rate at day 28. We are going also to move more to preventive treatments and to evaluate if we can perform some FMT to prevent gut microbiota dysbiosis and improve patients' outcome. And it will be studied in the phase 3 randomized double-blind control study against placebo. In this study, we will not use MAT13 that is given by enema, but a new product, MAT33, that is a full ecosystem microbiome restoration that is given by capsule orally for the patients, and this is frozen, so they don't need to keep this in the fridge. This is very easy for the patient, and this is some very small pills, so this is easy for them to swallow it. It will be given daily before we start the conditioning regimen for 2 weeks to restore the gut microbiota at baselines, and after neutrophil recovery up to 3 months, and we expect that it will allow us to improve patients' overall survivors. So to conclude, we think that FMT in acute graft-versus-host disease will allow the restorations of the microbial homeostasis. It increases gut microbiota diversity, eradicate multi-drug resistance bacteria, induce butyrate and immunoregulatory T cells with an immune homeostasis restorations and preventions or remissions of symptoms. So I would like to thank all my colleagues, and I will be happy to take questions
Thank you very much, Florent, for another beautiful talk. And I think it is very convincing that now we're ready, I would say, for prime time with microbiota modulation and manipulation. But obviously, the question that we all have, what kind of product should we use? And this is why Dr. Joël Dore, who has 30 years of track record of research in this field of microbiota, has kindly accepted to take the challenge to discuss the optimal product, the optimal microbiota product to be used actually in different disease and clinical settings with the pluses and minuses for every option. So thank you, Joël, for joining. We're very eager to listen to your talk. We're very eager to listen to your talk. Joël, you have to activate your microphone.
Okay, yeah. Sorry. Yeah. So I'm working with INRAE, with Metagenomic and Michaelis units. I'm co-founder of MadPharma, scientific advisor for the company, and I'm also co-founder of a few other small companies, recent companies. I need to find a way to progress on that. I'm sorry, I cannot move. Oh, here we go. So I will really emphasize in my presentation the fact that we are microbial, and we are, in that respect, symbiosis. And the relationship between the human and its microbes starts at the very moment of birth. And we, at the same time, develop our microbiota and mature our immune system, leading to several contributions of the microbiome to health and well-being that are listed in the center: utilization of food constituents, barrier function, i.e. prevention from proliferation of environmental microbes, including pathogens, stimulation of natural defenses, development of intestinal wall, and signals towards all organs of the human body, including the brain. That leads to this situation where the microbiota is recognized as part of self by the immune system. And this is the essence of symbiosis. Now, there are numerous clinical contexts, chronic affections, iatrogenic alterations, where we have been able to describe alterations of the microbiome. They are listed here. We've heard already of some of them. And what we have been able to describe is a common feature in those configurations, which is alteration of the microbiota. But over the past few years, we've come to realize that what we are really dealing with is an alteration of host microbes symbiosis, i.e. aside from alteration of the microbiota, which you've heard a lot about already, we have alteration of gut barrier, most often permeability, sometimes hyperpermeability, and that leads jointly to inflammation, sometimes only low-grade inflammation, but inflammation leads to oxidative stress. And as you can envision, these four triggers can actually turn in a circle. It was mentioned quite a lot already that the key features of the microbiota are gram-positive bacteria that are sensitive to oxidative stress, highly sensitive. Some are really highly sensitive to oxygen and oxygen radicals. And so that will possibly turn into circular causalities. And so altered host microbe symbiosis, together with circular causalities, will come with two aspects: threats on the one hand, meaning that altering just one element of the system may actually be sufficient to induce a vicious circle with the induction of a sustained alteration of the symbiosis. This is work I will illustrate in a coming slide that we published in 2020 in Microbiome, showing that inflammation could actually induce the alteration. But it comes with opportunities. We have four actionable levers or triggers that can be useful for diagnostic, for prediction, for prevention and therapy. And what I'm saying here is that we should not just count on the photography, the molecular assessment of the microbiome, but we should altogether combine this information with information on gut permeability, inflammation, and oxidative stress. Now, just to illustrate, what we have done is to demonstrate whether chronic inflammation alone could be sufficient to trigger a durable alteration of host microbe symbiosis. We're working with a rat model, and we use dextran sodium sulfate to induce inflammation. This is 3 courses of 3 days, separated by 15 days, and it's mild concentrations from 0 to 3%. But we do not look at the animals just after. We wait for 40 days, and then we address the question of whether we have had resilience, i.e. a return to the initial configuration in terms of microbiota and in terms of gut wall integrity, inflammation, or whether we have durable alteration with 2 parameters being durably altered, or possibly an intermediate situation with one of the parameters still altered after 40 days. And what we do see is that with a majority of animals from 0 to 1% DSS in drinking water, they will tend to revert to the initial configuration. They will be resilient. And the others will be possibly in an intermediate situation where either microbiota or gut wall will still be somewhat altered. But conversely, when we use 2 or 3% DSS, the majority of the animals will tend to be either in the intermediate situation or will show durable alteration. So we have a model that has been designed now that allows to set durable alteration of host microbe symbiosis, just inducing inflammation in the gut. And we address the question further, looking at the impact of alteration of symbiosis in the context of this cohort of more than 350 pediatric patients assessed by Schirmer and colleagues in 2018 under standard of care for 1 year for treatments of ulcerative colitis. And what they observed is that around 36% of the patients enter remission phase, leaving behind quite a large number of patients that will not revert in terms of microbiota or immune homeostasis. So we addressed the configuration of the microbiota or calprotectin in terms of how many states do we have for both. And we did observe four states for both of them, only one combinatorial state representing what we call remission here. And exploring further in terms of mathematics, the situation told us that if we consider only the possibility to remove inflammation, to use anti-inflammatory drugs, then calprotectin level would have to be below 0, which is just virtually impossible for the patient to return to normal in many cases. And similarly, if we were only altering the microbiota, we would have to have a more than normal microbiota, so to speak, for most of the patients to actually return to a remission phase. And so we speculate that combining immunotherapy together with microbiotherapy might be the best option to actually combine the forces towards remission. Now with MatPharma, and this is the example that Florent Malard was illustrating before, we have this proof of concept study where we use fecal microbiota transfer in an autologous manner, administering 2 enemas. For patients that have very diverse microbiota to start with, but following induction chemotherapy and antibiotic, we'll have a microbiota which is, as illustrated by Jonathan Peled for another one, highly dominated by one taxon, basically. There's just very few subdominant taxa remaining, but when we administer their own microbiome, then we completely reconstruct the configuration as essentially as it was before. And so this is the impact of autologous microbiota transfer with a conditioning of the microbiota that is highly respectful of the requirements in terms of physiology of the microbes. But it's a MAT12, it's a one donor, a single donor autologous transfer. We restore the microbiota as was illustrated. We restore quite nicely the butyrate producing component of the microbiota, and you know how this is important for immune modulation. And we also restore immune homeostasis, which is here indicated by the measurement of fecal neopterin, an indicator of the immune or inflammatory burst following induction chemotherapy and antibiotics that is completely resolved at B3. Now, you've seen that already. I will just stress the fact that MAT13 restores microbiome richness. It regenerates gut barriers, protective effects, and significantly curbs inflammation. One way to look at it is that it resets host microbe symbiosis into an immune responsive configuration. And the immune responsiveness is really what I want to stress. And just to illustrate that, in the review of RINS in Frontiers Immunology end of last year, what they illustrated is that the configuration of the microbiota is such that by the way it interacts with immune cells, it will just altogether favor the efficacy of the immune cells towards tumor killing in the context of immune checkpoint inhibitor treatment, as well as it will favor humoral immunity and cell-mediated immunity in the context of oral or systemic vaccination. So there are very few examples of multiple randomized controlled trials where we could actually do a meta-analysis comparing single donor versus pool IMPs. In fact, there is no single trial that did compare mono versus multi-donor microbiota transfer. But yet in ulcerative colitis, we have a number of studies. So we have reanalyzed what was available around 2021. And we show in that analysis that multi-donor pooled IMP perform better than monodonor IMPs. Now, what MaaT Pharma is doing is it's vetting a very large number of donor candidates through strict screening tests based on European consensus, guidelines from regulatory agencies, and that includes SARS-CoV-2 detection, obviously, today. It leads to full ecosystem biotherapeutic development, a standardized off-the-shelf CGMP condition manufacturing, and eventually what we get is this very highly consistent, high richness, high diversity product, which preserves the butyrate producers among the components of the microbiota, essentially the lactose paraceae and ruminococcaceae you heard about at the expense of proteobacteria, for example. Incidentally, just today, there was a press release commenting on the preliminary results based on interim analysis of a trial called SIMON, which is a phase 1b with MaaT33 with the dose ranging increasing levels with very positive engraftment results, actually. Just before I finish, I want to give you the measurements we have of the comparison between single donor and MaaT13, which is the pooled IMP of MaaT Pharma. What we have in terms of diversity based on inverse Simpson index is a much higher diversity of the MaaT13 compared to a number of single donors. That's true for diversity, that's true for richness, the simple alpha diversity measurement. And not only do we get a higher level, but we also have a more homogeneous level, less variance between preparations. And it also impacts the metabolome. This is an illustration of the metabolomes based on the measurements of hundreds of metabolites in stool samples from single donors, or in preparations from single donors versus a preparation from a pool. And what we do see is that the pool will cover a whole range in homogenized proportions of metabolomes that tend to be, for single donor, very specific of potential functionalities, targeted functionalities. And so overall, what I will use as a conclusion is pooled microbiota ecosystem therapeutics will perform better than monodonor therapeutics in their ability to increase richness that potentially will circumvent possible limitations of donor to recipient microbiota antagonism. They've been described in other contexts, such as probiotic administration, for example. That will favor consistent engraftment of most adapted symbionts. If you deliver a very high diversity microbiota, essentially you allow for ecological sorting following administration, and that will allow engraftment of most adapted symbionts, allow consistent restoration of key functionalities, including gut barrier. I may be able to take.
Thank you very much, Joël, for really exciting talk, and definitely this is good news. Products are now being made available for use in clinical practice in cancer, hematologic malignancies, allotransplant, but probably beyond at some point. So here I'd like to invite the faculty, Dr. Zitvogel, Dr. Peled, Dr. Malard, Dr. Dore to join me. And actually, we have a lot of questions. So I'll try to structure them by topics. So guys, if you don't hear a question immediately, it doesn't mean I have forgotten it. It's just in the tunnel, I would say, on the waiting list. So let's start first with, we have a bunch of questions about the role of microbiota in the pathophysiology, actually, of cancer. And maybe we can start with you, Laurence. So you have shown that dysbiosis is really a hallmark of cancer patient. Do we have an idea, because there are several questions in the same direction, whether there is a causality, between the advent of cancer and dysbiosis?
Yeah, so we showed that there is a causality, because if you block the reemergence of enteroclusters, for instance, with vancomycin, or if you treat with beta blockers, or if you do co-housing of mice bearing or not a cancer, you can completely interfere in the process of cancer-induced stress ileopathy. There is a causality between the implantation of the cancer and the dysbiosis.
Okay. So in line with this, do you think, and this is, let's say, Jonathan, because you mentioned, for instance, that a specific type of bacteria, specific species can be involved in a higher incidence of relapse, or in, lowering the incidence of relapse of whatever malignant hematologic disease after transplant. Is this in line with the what Dr. Zitvogel has just mentioned, or has it something to do with a sort of an interaction between the immune system and whatever species that will favor a sort of a graft versus leukemia effect or an immune-mediated response?
I think that's a key question, and it's an open one in the field. And one can envision a few different pathways by which the microbiome might modulate host physiology. One is by secreting a metabolite that, and we know that the metabolites are found at relatively high concentration in the circulation. Another is that specific antigens might be presented by antigen-presenting cells. Those mechanisms require that there be a specific antigen for each HLA type that matches the neoantigens of a tumor, for example, or the alloantigens of a GVHD target tissue with antigens on bacteria. The combinatorics of that are somewhat astounding, but it's still possible that there are nevertheless patterns that explain that sort of thing. So a third pathway might be that bacteria invade into the mesentery, or at least into the lymphatics, and modulate physiology. I also have to take liberty just for 1 minute. I realized that I neglected to include an acknowledgement slide at the end of my talk, and I apologize for that. I just wanted to briefly acknowledge my mentor, Marcel Vandenbrink, and the other and my collaborators at other centers with whom I did all the work, and I thank you for that indulgence.
No worry for this, Jonathan. What are your thoughts on this topic, Joël?
I think that the question might actually relate to the potential of there being bacteria that are specifically inducers of cancer. And if this is the case, I mean, we have a few examples of bacterial taxa that have been pointed out as potential inducers, but it's specifically dealing with colon cancer for the moment in the literature. And there's probably much more to do, but Fusobacterium nucleatum, for example, has been popping up, and another bacterium, Streptococcus bovis, has been also claimed as a potential contributor to induction.
But I think, Florent, in your Nature communication paper with AML patient, you didn't see any dysbiosis at diagnosis of AML, correct?
No, in fact, we have the data from the 25 patients, but in fact, we screened more than 60 patients, and some of them were excluded because there is already some drug resistance bacteria. And in fact, we don't analyze the dysbiosis in those patients. And it will be, in fact, very interesting to analyze if there is already some dysbiosis in some of the patients, because maybe they are excluded and not analyzed. In fact, given the exclusion criteria, we focus on the 25 patients that did not have dysbiosis.
Okay, so that's really something exciting for the future, the involvement of the microbiota in the etiology of some cancers, because that will pave the way for maybe some prevention. Who knows? So all of you, I think, alluded to the major problem we face, which is about dysbiosis. And we have a few questions about how to measure dysbiosis. Is there a unique tool? Is there an optimal tool? Or maybe now we have more easy to do tools like looking into the concentration of soluble MATCAM1 that you have nicely shown, Laurence. So who would like to start? Maybe Joël, you can start because maybe you have the historical perspective on how to measure dysbiosis or quantify it, if I can say this.
I think I'm somewhat biased because I thank Laurence for saying that we helped out by the tools we were providing, which was essentially shotgun metagenomics, and I think that we learn so much more using shotgun metagenomics than when we just target one gene, or when we use PCR. That I still do at this stage favor really a lot the potential offered by shotgun metagenomics that allow to scan all the dominant genes and essentially be able to reconstruct not only the diversity in terms of taxonomy, but also the potential pathways that are modulated. And so I would favor that. And I really love the field of we are addressing today, because it's contributing really significantly to the observation that we have recurrent features. It's not just randomly moving around. It's recurrent features that we see in many different conditions where the optimal configuration of the microbiome has to be highly diverse. It has to be dominated by gram-positive bacteria of the Firmicutes phylum that are Lactobacillus or Ruminococcacea related, and they have to occupy the space and not leave space for Proteobacteria, Sutterella, Enterobacteriaceae, or Enterobacteria in general. And so this is really, for me, telling a lot. Now, the details probably have to be refined, but what we are seeing is to me very very important, and probably the source of potential innovations.
So, Joël, I think everybody's now convinced that dysbiosis is a major problem, and maybe we need to check for it on a more routine basis. Mm-hmm. But then your proposal about metagenomics may not be the easiest thing to do on a daily basis. So the question is about what are the tools that we can apply, like what we do, on a routine basis every day. In the morning, we would look into the white blood cell count, the CBC, or whatever. Any thought on this, Laurence? And then I'll give it to Jonathan and Florent.
Yeah, so indeed, even though the tools for shotgun metagenomics analysis will improve and will improve fast, I believe, yeah, we are stuck on a routine clinical basis with more simpler friendly user test. So at the moment, there is a paper that will be it's in press in Nature Medicine from Lisa De Rosa. So we found, let's say, shortcuts, meaning that we looked at surrogates, and we found that there is a close correlation between high amounts of Akkermansia, which are above the Gaussian curve of the Akkermansia accumulation. And this is associated with enteroclusters and associated with proteobacteria, etc., as opposed to normal levels of Akkermansia, which resemble what we would say a rich flora, and the Akkermansia negative, which also is, let's say, a surrogate of a defective microbiota. So in other words, maybe we are hopeful, at least we are trying to use PCR-based probes to identify the semi-quantitative amount of Akkermansia mucinifila, and we use that, or Akkermansia species, to try to delineate the very dysbiosis from the normality, let's say. And we also use soluble MADCAM, so that's something that we are learning, and we are not completely, we need some more validation from other authors, but I am hopeful that progressively other investigators will found surrogates, proxies of dysbiosis that could highly correlate with the taxonomic composition as defined by shotgun metagenomics.
So your efforts are concentrated on surrogate markers.
Yes.
How is the situation in your lab, Jonathan?
Well, I wanted to point out that Ernst Haller and Regensburg has studied the urine concentration of 3-indoxyl sulfate, which is a tryptophan metabolite that is produced predominantly by Clostridia, such as these Lactospiraceae that we're all talking about. And that is measurable by mass spectrometry in a rapid, potentially in a rapid turnaround fashion, the way drug PK levels are measured, for example. And that single biomarker in single center studies has shown to correlate with both with diversity of the gut microbiome as assessed by sequencing and with transplant-related mortality. So I think there's a lot of interest in 3-indoxyl sulfate from that perspective. And there are probably other metabolites that might behave and offer similar summary metrics. I'll also make one other comment, which is that we've tried to analyze our sequencing data in such a way that we can narrow down the universe of all the bacteria into 1 to 200 key taxonomic groups that we then assign we calculate a coefficient for each in regularized regression, and then derive a risk score so that one can either use sequencing or PCR approaches, as you mentioned, Dr. Zitvogel, for key indicator strains, and perhaps assign a risk score based on that using linear regression.
Well, excellent. So, but I think there is an agreement that at some point when you are in front of a patient, like we test routinely for the kidney function, the liver function, we need maybe to move into checking the dysbiosis status. And that brings me to the second group of questions, which is about how to influence or to correct, to restore dysbiosis without the FMT or the pharmacologic intervention. We have a few questions, actually. Maybe I can start with you, Florent. So you're dealing with hematologic diseases and allogenic stem cell transplantation, and both your data, Jonathan data, have shown the impact of low diversity. But one striking parameter for me is that, and I'm part of the group, you know, I'm among the people who are to blame, is that for our patients, for these patients who have really low diversity, actually we are extremely restrictive in terms of diet. Whereas maybe having a rich diet, rich with fiber. This is what you have shown. So how would we explain this contradiction that our historical medical approach is about being extremely conservative, very restrictive, whereas now we have evidence that you need huge diversity?
So this is not an easy question. In fact, a long time ago, we think that we need only to give some sterile food to the patients to have some gut decontaminations to avoid any bacteria. But if we want to be effective, we need that there is absolutely no bacteria. Because in fact, with this kind of procedures, in around half of the patients, we did not have any bacteria, and this is beneficial. But for the half of the patients, in fact, will induce some dysbiosis, and it will not be an effective treatment to use gut decontaminations and to give them sterile foods. So we are going to move the paradigm. So we stop gut decontaminations, but we are still going to give to the patients some sterile foods and very restrictive regimens. And I think now we should modify these kinds of regimens for the patients, and we should start being less restrictive to allow them to eat some more diverse food and to evaluate the impact on the gut bacteria compositions and of the patient's outcomes.
Wonderful, thank you, Florent. Joel, we have a few, I think, nice practical questions from our audience. For instance, I mean, you hear about diet everywhere, about nutrition supplements, etc. How long does it take actually to modify your microbiota richness or diversity if you modify your diet, and how stable is this?
Yeah, so we've modified with data from interventions that are usually spanning a few weeks. We have data from the group of Jeff Gordon in the US showing that within 2 days, you already see an impact on the metabolism, on the transcriptome of the gut microbiome, so it can be very rapid. And in terms of stability, when we worked with overweight and obese individuals, we can actually restore higher diversity within 6 weeks. And well, we stop intervention, but 6 weeks later, up to 12 weeks, sorry, we still have an impact that is really highly significant. So, so I'd say that just the fiber impact will take a few weeks to make its impact, but then it will be reasonably stable unless you completely switch back to a very low diversity diet, because what matters is not just the presence of potato starch, for example, but it's the diversity of the fibers you're putting in the system. Now, if I just can comment on the previous question, where you were thinking of how we can reconstruct in the context of such severe conditions. I mean, it's like you were thinking of restoring the garden after a storm, or restoring the garden after an atomic bomb, basically. I think that some of the treatments that we use in cancer treatment are so harsh for the microbiome that it's very difficult for me to imagine that it will just be sufficient by diet to do the job. So this is why I think re-administering microbes might help quite a lot.
Okay, thank you very much for clarifying this. Here I have a question from Dr. Matthias Wolf. And maybe I can direct this to you, Laurence, is about, you have nicely shown in cancer patients the deleterious impact of antibiotics in generating dysbiosis and at some point resistance to checkpoint inhibitors and maybe other immune therapies. But then the question is that by our colleague is that there is a reason why these patients are getting antibiotics. So how would you, I would say, sort out the story of the chicken and the egg before or after? What are your thoughts on this issue?
Yeah, so First of all, antibiotics, when they are needed, have to be, of course, administered because it's life-threatening to have a bacteriemia or septicemia. Of course, there is no question about that. Now, when you can wait for the PD-1 blockade to be administered, it's better to wait for 3 weeks after antibiotic stop to administer the first antibody treatment. However, there is another good news. The good news is that if you combine chemotherapy together with immunotherapy, now the antibiotics are not anymore harmful. The reason is that this has to be somehow demonstrated, but my insight is that to fit with this epidemiological data showing that antibiotics will not be so harmful if immunotherapy is combined to chemotherapy is exactly what I was alluding at, meaning that the Tregs from the gut, when they leave the gut to go to the cancer, they are very sensitive to chemotherapy, notably to cisplatinum salts. And I would say that this hyperprogression, which is due to Tregs, could be potentially blocked by cisplatinum. So we are going to try to address this formally, experimentally. So I am trying to hope that the combination of chemoimmunotherapy would be the answer for those patients that present to the clinic with antibiotic uptake.
Thank you, Laurent. So we have several questions actually about the antibiotics. I mean, one comment from the audience was that anyway, with our current treatments in hematology and cancer, antibiotics are here to stay. So with this in mind, and maybe you can take this one, Florent, are there good and bad antibiotics?
So yes, there may be some good and bad antibiotics. I think that most of the antibiotics are bad, but we don't have the choice and we need to use antibiotics for our patients. And in fact, when you're going to use antibiotics, you have to think first to the prognosis of the patients and what are going to treat. Because if you think that, yes, I should avoid these very bad antibiotics, but at the end, you don't treat the good bacteria and the patients can die, it's not the good things to do. But we know that the antibiotic with the large anti-anaerobic coverage, such as imipenem, meropenem, have a bigger impact on the gut microbiota and should be avoided at least for the first treatments. And that antibiotics such as cefepime seems to have a less anti-anaerobic effect and should be the best first-line treatments. Regarding also the prophylactic antibiotics, some centers did not use any prophylactic antibiotics. Some of them use ciprofloxacin, and it seems to have a detrimental effect. And there is also some antibiotics with less effects, such as rifaximin, that is used, for example, by Professor Holler in Regensburg, that seems to have some very interesting effects. So there is still something we need to explore to know what is the best prophylactic antibiotics and to combine with the first-line treatments of antibiotics.
If I may add to that also, when the Infectious Disease Society of America published their recent update to their guidelines on prophylaxis during cancer treatment, there was an interesting debate in the pages of the correspondence section of the Journal of Clinical Oncology, in which some authors argued that the paradigm of gram-negative prophylaxis that we all use in our neutropenic patients preceded the era of recognition of how important it is to initiate broad-spectrum antibiotics the moment clinical sepsis is recognized. And these sepsis bundles that we have now that we get dinged for if our departments fail to administer antibiotics within 1 hour of the fever and the tachycardia is a different world than when gram-negative prophylaxis began. Now, I don't know what the answer is, but there is a debate now about whether in the modern era we should reevaluate keeping patients on gram-negative prophylaxis just because they're neutropenic, especially if they're in a hospital where antibiotics can be administered within minutes of the fever.
Well, My short answer, Jonathan, definitely we need to reevaluate, because actually you're using paradigm from 30 or 40 years ago, and time has come, I think, to revisit this. One last question about antibiotics before moving to another group of questions. Maybe Laurence, you can take this one about vancomycin. We have a question that vancomycin can reduce the microbiota diversity, especially the ones that produce butyrate. So you have dysbiosis, but it doesn't look like that vancomycin has a deleterious effect on the activity of immune checkpoint inhibitor. Is this correct?
Yeah, this seems to be correct. This is a short answer.
And is there any explanation for this?
Yeah, because it kills these enteroclusters that dominates the scenario, the landscape, when the tumor is growing. And these bacteria killed by vancomycin are those bacteria that dampen MADCAM expression, etc. So I start believing that what has been described earlier before us was actually right. And in fact, some people use vancomycin in the conditioning prior to FMT transfer, and it sounds maybe as a good idea, at least in the setting of immune checkpoint inhibitors.
Wonderful. Actually, you gave me a nice transition, Laurence, to speak about now the treatments and the modulation of the microbiota, and especially the use of FMT. So I'll start by taking a few general questions about the modulation of the microbiota. Usually when we speak about FMT, we think about the gut, but actually we have a question here which I think is very important, and we've seen this recently in a Nature paper, I think, by Nagler and colleagues. Can FMT impact the diversity and composition of the tumor microbiota? Because we know that the tumor microbiota, the bacteria infiltrating the tumor, can also play a role. And I think that was shown in melanoma in this Nature paper. Maybe Joël, you can comment on this.
Well, it's a tricky question. I think the bacteria that end up in tissues overall in the human body have to have been transported, carried, conveyed by immune cells, including dendritic cells, for example. And so I guess if you completely change the gut microbiota, you can expect that those circulating in the body will be different, and that might impact the tumor microbiome. But my perception is that it will not be a quick response, because those microbes that actually manage to survive in tumors are probably there because ecologically they are very pleased. They find their ecosystem in a way, and so it will be complicated to displace them. But it's highly speculative, I would say.
Thank you, Joël. Very clear answer. Maybe you can take this one, Jonathan, from Dr. Barbado. You alluded very quickly to the work of Melody Smith and the interactions between the microbiota and CAR-T cell efficacy, but maybe also, I don't know, neurotoxicity. Can you expand a little bit further on this?
Sure. There's a paper that's forthcoming that Melody has written, but there are some trends toward higher rates of toxicity and in patients who have prior antibiotic exposure, and some trends toward improved tumor responses in patients who were spared. In other words, the ones who were not exposed to antibiotics tended to do better, both with respect to tumor response rates and toxicity. I can't describe in great detail the specifics of the forthcoming paper, but I know that there are several groups actively working in this area. And what I would say more about it though is the key question is the mechanism. Why is it that something in the microbiome would modulate something like neurotoxicity? And one might speculate that the lymphocytes that live in the gut might act as cytokine pools or sinks, if you will. And so anything that might modulate the pool of lymphocytes that reside in the gut might then in turn affect cytokine levels throughout the body. That's one mechanism one might speculate about.
No, thank you, Jonathan. And that brings me to just mention a comment we received that there is likely a link between Alzheimer's disease and the gut microbiota and dysbiosis. I'm not an expert in this field, and that goes beyond, I think, our topic today, but definitely I think dysbiosis in the microbiota is being now involved in many disease settings, but I wanted just to mention the comment we received about this issue. Florent, if we continue in this FMT use in clinical practice, do you believe that a certain species or bacteria are more or less important in the FMT? And then I will direct this to Joelle, who nicely showed that actually we need a very rich product to be effective.
Yeah, we know that we need the gut microbiota restorations. We have some data from the Heracles trial that I show you that it is important to have a low diversity to have a good engraftment of the product. So it seems more that it will depend on what we have at baseline in the patients when we're going to treat graft-versus-host disease more than which is the good bacteria in the product. I think what is important is that we need to restore the gut microbiota and to give this kind of high diversity product.
So that brings me, Joelle, we have several questions because there are, it looks to me, sort of different philosophies there. So either you pool everything and you offer your patient a sort of a variety of content, and then the link between the interaction can take place and the host can choose whatever needed, or we do have apparently approaches being developed trying really to target a very specific bacteria or species. Can you maybe expand on this? Because I think you have shown some very nice data comparing single donors versus a pooled product.
Yeah, I think that as I tried to explain, what matters is not just the microbiota, it's really the microbiome immunome relationship, I would say, to make it even simpler than probably what it is in reality. But still, this interaction is really key. And what we tend to realize at this point is that diversity matters, not just because it's diversity, but because it's really coming with a high representation of gram-positive bacteria of the Lactobacillus, Ruminococcacea families, and this is what will probably explain why this has an impact, a positive impact on the modulation of the immune tone and on allowing the responsiveness of the immune system in a better way. And so, yeah, I think that if you realize that in some cases what you will have is a completely wiped out microbiota, you will have just a few taxa that are dominating, then what you want to do is to essentially restore a very rich microbiome. But there was someone before, there was a long time adaptation of the immune system with a given microbiome before. And so if you add a high diversity, then you give chances of the potential for a high diverse microbiota to reestablish and to reset the intimate interaction with the present immune system and the previous microbiome. So it's not just microbial ecology, it's microbial ecology within the immunome microbiome interactive system.
So that just to clarify, this means that for all of us, assuming we have normal microbiota, but actually the definition of what is normal is different from one individual, and it's a range, and having a pooled product would allow you to put together all of these normal microbiota. Did I summarize it?
Yes. One of the key surprises we had using shotgun metagenomics is that when we were looking for the description of the average human in terms of microbial ecology configuration, we did not find an average human. There are at least three complete different settings of microbial ecologies in the human gut, which we have called enterotypes. And so if you administer one enterotype into another one, well, at this stage, we don't know what happens, but it might be very complicated in terms of ecology to restructure a highly diverse microbiome. Whereas if you actually flood the system with a high diversity of microbes coming from diverse donors, then you actually allow the system to have much more chances to rebuild. I think still that when I say that, it's just saying that we know so little in terms of ecology. Knowing or mastering ecological engineering is very complicated. And so this is probably why. I mean, at this stage, I think that the best way to go is to actually administer a highly diverse system. At some point, we may know enough that we can actually personalize or refine the composition of the IMP that you want to administer with this or that person, depending on what they were before in terms of microbial ecology.
Excellent, thank you. So maybe Florent, because you have shown some very impressive results in refractory acute GVHD, which is a life-threatening condition. Can you comment, we have a question here, on the efficacy and safety, for instance, in these very fragile patients using a sort of a consortia of bacteria versus the product you have used, which is a pooled donor product? What are your thoughts on this?
So I don't have the data regarding the use of the consortia of bacteria. I only have the data on the product. And in fact, when we look, because I show you with the compassionate use programs on the protocol, we treated more than 70 patients. And in fact, the incidence of bacteremia in these patients is around 20%. No bacteremia within 24 of the treatments. And when we compare with some historical control of patients with GI acute graft-versus-host disease, the incidence of bacteremia is more around 30%. So we have a lower incidence of bacteremia with this kind of treatments. So regarding the safety of a product, we think that we are safe, and maybe it can reduce the incidence of this kind of complications. We should not fear to have some infectious complications because of the use of this product with a lot of bacteria, and that because we are going to use more bacteria, we will have more risk of infectious complications.
So Jonathan, what are, I mean, you're really on the lead on trying to correct dysbiosis in your patient. What are your thoughts? We have a nice question here. How to select patient who should receive FMT? I mean, Florent has shown protocols in patients who are already suffering from a specific condition. Here, maybe the question is slightly different in terms maybe of prevention or prophylaxis. Any thoughts on this? Any work planned?
I mean, that's a great question. I'll tell you about a trial that we're excited to have just opened in collaboration with our colleagues at Series Therapeutics, who have rationally selected strains from their library and assembled them into a designed probiotic, if you will, which is designed to do such things as confer colonization resistance against Enterococcus and improve gut barrier function and hopefully reduce GVHD and infections. So to whom to give this? As we discussed at the beginning of this roundtable, there is no good way currently to assess the health of someone's gut microbiome in time to enroll them in a clinical trial. To say nothing of make live clinical decisions, even for trial enrollment, there's nothing yet. So we're using the fact that the patient is about to undergo a bone marrow transplantation as the nuclear bomb, if you will, that Dr. Dore referred to. So So what we're doing is we're administering this cocktail of bacteria both before the bone marrow transplant, before conditioning, and immediately after neutrophil engraftment. And a third time if the patient receives a course of antibiotics in the first 100 days following their transplant. So 2 to 3, maybe even 4 rounds of treatment, depending on how the patient goes. In a sense, trying to totally take over the gut microbiome with what the company thinks is the ideal composition.
So maybe, Joël, you can comment on this issue of using strains of bacteria versus what you have very elegantly shown. And we have, for instance, a few questions about how to anticipate or ensure the reproducibility of these pooled products versus the less rich products based on strains, etc. Any thoughts?
I'll just give an example of work we've done with probiotic. Actually, it's a mix of fermented milk bacteria, and what we showed is that in our animal models, but it was reminiscent from human data. If we take sufficient animals, then we essentially have 2 types of behaviors. Even in animals that are, lines of animals bred in the same configuration and so on, there's one that is permissive, that will actually allow high persistence of the microbes for a longer time, and half of them which are less permissive, which are less tolerant to the persistence of the microbiota, that will eliminate very rapidly. And I think that in terms of ecology, that's the best example I can give, meaning that depending on who is the recipient microbiota, there will also be an impact. So people think of a super donor microbiome, but depending on who it's administered to, it will not behave the same. And so there's stronger ecological rules that we have yet to understand, but that will drive the efficacy of the ecological behavior. And I think if you use a small cocktail, small consortia, then the trend will be very high to observe this kind of behavior.
Excellent. Thank you very much. One last question, because time is running. For you, Laurence, in solid tumors, what are the current situations or indications for microbiota modulation, whether using the MAT13, the MAT33, or any other product? What are your what do you think are the directions in terms of solid tumors? Because we heard from Florent the different directions and indications. Jonathan also mentioned this in hematology. What about solid tumors? You need to activate your we can't hear Laurence.
No.
Microphone is activated, but my connection is not so good at the moment.
It's working.
So please go, Laurence. Go on. We can hear
working.
you.
So I was saying that when the cancer is actually creating this dysbiosis, then we absolutely need to correct this dysbiosis. Otherwise, chemotherapy or immunotherapy will not work full-fledged. So the indications might be actually very broad, I am afraid. But the future will tell us more.
Excellent. Thank you very much, Laurence, Florent, Jonathan, Joël. There are also plenty of questions that, unfortunately, for the sake of time, we couldn't take. Any question? There were some questions related to the manufacturing, the specifications of the product that were mentioned, like MAT13, MAT33. So here, I would kindly ask you to direct your questions to the company MAT Pharma, and I'm sure the guys will kindly answer these questions. You can also connect for other questions with our top faculty. I think, guys, you did really a fantastic job tonight, because in roughly 2 hours, you managed to walk us through this superb journey about the interactions of the microbiota in cancer in general, whether solid tumor. And thank you, Laurence, really for the pioneering work and for paving the way for all of this research. Thank you, Joël, for 3 decades of work on trying to bring this microbiota story into the front line of human disease. Thank you, Jonathan, for working in the last decade on trying to discover the impact of dysbiosis and the role of microbiota in hematologic malignancies. And last but not least, thank you, Florent, for taking this into clinical practice and showing that we can really improve the outcome of hematology patient, whether transplanted or not transplanted, by modulating the microbiota. I think this is the beginning of this fantastic adventure. So please all stay tuned. This has been really a terrific webinar. The webinar will be available on demand at some point in the next few weeks at the Academy website, clinical-hematology.org. And I would like to thank you all for your loyalty to the IACH activities. You were several hundred of people connected tonight. This is really amazing, and how people are excited about this microbiota topic. So wherever you are, please stay safe, keep well, and take care of microbiota, of your microbiota. Thank you very much. Good night.
Thank you, Mohamed. Thank you.
Thank you.
Thank you. Have a good day. Good
Bye-bye
evening.
now.